My name's Sharon. Hi, my name's Sharon. I'm Fertility Network. Tonight we're bringing you a webinar to talk about how to achieve a pregnancy after the age of 40. The charity try our best to try and work with our corporate partners, and tonight we're working with Ovogene, and Dr Uliana is going to take over and she will go through exactly what the issues are in relation to egg quality as we start to get older. If you've got any questions, please just pop them in the chat box, and at the end of the presentation by Dr Uliana, I will ask those questions on your behalf. This webinar has been recorded, but there's no identifiable information that will identify who's asking those questions, so please feel free to ask anything you want in relation to this webinar. I've got additional questions that other patients couldn't make tonight have asked me, so there'll be lots of chat at the end of it. The webinar will finish at 7:45, so we've only got so long to do this, so I'll try and answer as many questions as possible, but if there's any questions that don't get answered, I'll get those answered separately and put it out on our website and on social media. So without further ado, I'll hand over to Dr Uliana. Dr Uliana, welcome.
Thank you so much, dear Sharon, for the kind introduction and for inviting us to be a partner during this webinar. That is my great pleasure to talk to you during this evening, and I will be happy to spend the next hour together with all of our attendants. My name is Dr Uliana Dorofeyava. I am fertility specialist. I was graduated in Ukraine. However, I received my practical experience in Ireland, in Israel, in other countries in Europe. I was mostly dedicated for treating international couples in Ukraine during many, many years. And last 10 years, I'm dedicated to the practical experience of the oocyte banking. So I love to talk about pregnancies for advanced maternal age, for different options, how to achieve the successful pregnancy. And I hope you will enjoy this time together with us. I am the founder and the director of the clinical operations for Ovogene. So let's talk about the topic itself. And according to the global data, and this data includes all patients in their different ages and different populations of the patients, including single women, lesbian and gay couples. So the total number of patients who are seeking for the fertility help is over 90 million people all over the globe. And the recent data for 5 years ago, it was saying that 10% of this population would need the oocyte donation. However, this percentage increased globally and significantly during the last several years. And now we are talking about the need even up to 30%, but definitely between 20 to 25% of each clinic in each location would request the oocyte donation as their only treatment option available, or the most effective treatment options for them to get pregnant. We know that the regulations globally are different, and some people are really happy and they have access to the oocyte donation in their home country, but in many countries it is so regulated that it is impossible to be treated in their home country, so they need to travel. As well, in some countries, oocyte donation is not that commonly available, so there is a huge waiting list. As well, this is something what can be true for the UK, as we are going to talk about UK mostly during this evening. So that's why the need is really, really huge. If you are talking about goals for the reproduction, the way until getting into the IVF could be long for many, many patients. But however, during a time when we are receiving the message from the patient, yes, we are ready to go, we are ready for IVF treatment, we understand this is our opportunity, please suggest us the best options available. So we have, as a reproductive specialist as a doctor, as a team, together with the patient being responsible for the success of this treatment, we have a goal to achieve the pregnancy as soon as possible, to maximize the success rate for the initial and the first treatment cycle as much as we can do this. So this is not always an option. We understand this is not a miracle IVF that we will get a success in 100%. However, we need to maximize the chances and we need to use all the options available for that. We need to reduce the multiple pregnancies and guarantee the safety in the IVF, and to help as many patients as possible. Many patients are looking for the reduced costs, so we need to think about as well how this is possible. We are understanding the law limits and the regulations, so that's why we need to offer the solutions from the global availability and use the most effective techniques and technologies which may help as well to reach all the goals which we were saying before. So we need to remember that our biological clock is always running, and for every woman, every minute, every day, every month, we are losing our reproductive potential. And the most effective is to receive treatment and to plan our family until the time of 35 years old. However, this is not always possible, and we understand different reasons, and this is happening, that many of our patients are over. I did the statistics, and for example, our data says that the average age of our patients being treated practically is 42 years old. So this is not always true that we are working with the young population and the positive potential positive outcomes. And the oocytes which we are losing, it's 99.9%. So we are trying to alert all patients that until you are in the fertility age, you are young, you need to freeze your oocytes if this is possible. However, this started to be possible only recently, and until several years ago, almost no, not social medias, not newsletters or the newspapers or the TV or the doctors were talking about this potential. So that's why this option is really limited for many patients, and age is crucial. Also, there is a data which is published in the UK, which is gathered in the UK, and saying that the average age of the first delivery in the world is increasing, and every decade, age of the woman delivering the first baby is increasing by 2 years. And if we will follow the trend, so in 2100, the first deliveries, they will be happening not over 30 years old as it is right now in the UK, and 1 in 25 UK births are women over 40 years old. However, that will be 50 years old and older. And in general, population is living longer, and we are living much healthier lives. And we have anti-aging therapies for many, for our beauty, for many functions in our bodies. So we need to understand that we as a fertility specialists, we need to be ready to offer the opportunities and such opportunities which will be working effectively for such the patients. So taking into account the statistics and our fertility statistics, why we are saying that if we would freeze the eggs, we may use them in the future, because we can see the graphs and the data clearly says that while we are getting older, we are losing our potential to produce healthy oocytes, we are losing our potential for the effective pregnancy and the positive clinical outcomes. However, if we would be using the oocytes which were frozen before, or we will be using donor oocytes like a young oocytes with the high potential, we will keep a reasonable high clinical pregnancy rate, which is over 50%, and even now it's potential to be higher, and we will talk about these options, how to achieve these results to be higher. So this is the way how we can achieve successful pregnancy for the patients in any age by using young and healthy oocytes for their treatment. So before moving forward, let's talk about what is the oocyte and which organelles, which structures are important in to keep being responsible for the further producement of the embryo and the baby. So IVF is performed to help to achieve pregnancy, and the poor egg quality is one of the main causes of the repeated failures in the IVF, and this is predominant if you are talking about what is more important, egg or the sperm. There were a lot of discussions about this between the patients, between the doctors, and even the scientific society. So we have one of the ideas, scientific idea, that 70% for the treatment for the further development of the embryo, this is the responsibility of the egg, and the 30% it's a responsibility of the sperm. So the quality of the oocyte is mainly determined by the small organelles which are located in the cytoplasm of the egg. So you can see a big cell on the screen, and the big round circle is cytoplasm. The small round circle on the top, it's a polar body. There is a perivitallin space, and there is a zona pellucida. So all these organelles, while we are analyzing them, while we are measuring them, they are very important in terms of the morphological development of the oocyte and what is inside, what cannot be seen in the regular microscope, because this is a screen from the regular microscope, what usually embryologist sees once we are receiving a cohort of the oocytes. So inside of the cytoplasma, these small organelles, which are really important, are the mitochondria and the spindle. So what is the mitochondria? It's like a battery for the cell. Mitochondria is producing the energy for the further development, for the proper fertilization, and for the growth of the embryo until the blastocyst stage and further. So this is very, very important part of the oocyte, which is responsible for its function. While we are getting older and the oocytes are getting older, we are losing the numbers of the mitochondrial DNA, and the mitochondrial DNA are losing their potential. So they are producing less and less energy. This causes the problems with the fertilization, with the calcium being sent further and over during the channels. So with the aging, we are getting the mitochondrial dysfunction. This is how we see the lower fertilization rate, lower blastocyst development, and the higher aneuploidity rates in general for the production of the embryos in the cohort. As well, we have very important organelle which names spindle. Spindle is responsible for the dividing the DNA equally. So this is a potential, it's a genetic potential of the egg in order to produce, to have a zygote, to have two pronucleuses inside the cell, which further will develop to the embryo. So if we have problem with the either mitochondria producing the energy for the cell, or we have problem with the spindle, we will have no fertilization and no further development for the embryos. How can we determine the spindle? It's from one side technically very easy process, because you need to have an equipment and you need to have a knowledge about this. But so you can determine this with only a special software and the polarization microscope, which is connected to the regular microscope. And this is how you can see the spindle. And embryologists usually looking into this after they taking the oocyte cell complex from the oocyte. So this is after 2 hours after the oocyte pickup and directly before the ICSI is performed. Spindle view system is used in very limited number of the clinics in the world. This is something what we are discussing now a lot, but still it's not in the regular, like a daily clinical practice in many centers. System also needs an experienced specialists and high costs investment. So maybe this is a reason why it is still not that common. So if we are talking about full IVF cycle, I'm sure that many of you have been through this, but let's talk about this from the point that we are talking about the advanced maternal age patients and those patients who have very low IMH and the very limited ovarian reserve. So in order to start the stimulation for such a patients, we need to select the optimal treatment regimen, like the optimal medication, which should be recommended, the optimal dosage. And this is very individual. So we can talk about, and this is absolutely different topic, to offer the best stimulation strategy for each patient. And again, this is very, very individual because we need to evaluate the medical anamnesis of this patient. We need to see if we had previous treatment cycles, what was the outcome, how we were reacting into the different medication dosage. Either we should consider like a duo stim or the mild stimulation or the natural cycle, or maybe random start stimulation. So these are all different options. And once we started the stimulation, we are following the monitoring of the cycle, following the follicular growth, and we may see several follicles growing. We need to decide about the best trigger timing and the best option for the triggering, as well as we are having different medications to select from for the stimulation. We have two options for the trigger injection. This is agonist triggering or the RCG triggering, or we may consider combined trigger in order as well to optimize the outcome. And once we received we punctured the follicle, we did the egg retrieval, we received several oocytes, depending on the reserve initial, we are checking the morphology of this oocyte. So we may receive M2 oocyte, and this is our aim, to receive M2 oocytes, and the proper cohort as a response for the proper stimulation should be to have at least 80% of the M2 oocytes in the cohort. Some eggs, they can be M1, and then the laboratory could consider to mature them in the lab until the M2. Some laboratories do not consider this as well. This is very individual in each laboratory. Some eggs will be GV, so this is meaning they should not be selected to continue to be fertilized, etc. So, and then we are creating the embryo. If we are lucky enough and we have enough oocytes, and then they fertilized properly and we have an embryo. So for this category of the patients, genetic testing of the embryo really should be recommended, because there is a high presence of the aneuploid deteriorate of the mosaic embryos and the aneuploid embryos, which should not be recommended to be transferred. Because if we are getting back into our goal to optimize the success rate and to maximize the chances, so the NGS testing for the embryos, this is the way how to optimize the chances, and not to give to the patient false expectations of just having a transfer of non-tested embryo with the high potential for this embryo to be aneuploid. So that's why the NGS testing really should be recommended. One of the options for the patients can be, for such patients, if we receive very limited number of the oocytes, is to repeat the cycles and accumulate more oocytes or more zygotes. However, this is not always the option, not always possible options for every patient. So that's why they need an alternative, or they need some solution which will give them higher expectation and higher success rates. So this is the data which is coming from the huge population of the tested oocytes. So you can see how the aneuploidity rate, or the percentage of the abnormal embryos, is increasing with age of the patients. So already for the young patients in any age, even for the oocyte donors, and we were very curious about this, and we actually proved this on our data of the donor oocytes. We did the testing of the polar body. So we saw the small circle on the top of the oocyte. So we did the biopsy of this polar body from our donors, and it was almost 2,000 oocytes, and we test them, and we received the 24% of those eggs, they were aneuploid. So this is a genetic testing of the oocyte. So still, every woman in any age is producing healthy genetically healthy and unhealthy oocytes. So this we need to consider. However, if this is a young patient, so this is only 20 to 30%, as we also have proven. If we are over 35 years old, it's already 40% of those oocytes and the coming embryos, which will be aneuploid. If we are up to 40%, it's already 50%. And if we are over 40 years old, we have even much higher percentage, like 70, 85% or so. That's why it is so important to test. If we have an option to test the oocytes, that's great. If we, at least, if not, so we are testing the embryos and then optimizing. We are transferring only euploid embryos. Euploid embryos have a high potential to implant. For those patients for whom we are receiving only few oocytes, or we have a huge risk that out of this cohort of the oocyte, we will not receive the blastocyst, or we were not receiving in the previous cycles, we really would recommend the combined oocyte donation cycle, so-called. That's usually recommended for the patients with the low ovarian reserve, for those who are not fully ready just for the regular oocyte donation, but they would like to have a last trial. They want to have still one chance to create their own, produce their own oocytes, create their own embryos. If that will not work, on a day of the oocyte pickup, we are offering to thaw several oocytes, like another cohort of the donor oocytes. At the same day, they are fertilized with the partner sperm, and we cultivate them in two different dishes simultaneously, and we are controlling how the embryo development is performed, and we are selecting these embryos which are high quality blastocysts, or we may decide to test them first as well, but at least we are not losing potential of having blastocysts in this cycle, and we are not losing the fact that we are having an embryo transfer, which gives us the hope and the potential to get a clinical pregnancy rate. So if we are talking about causes of the poor oocyte quality, in addition to the fact that this is a maternal age and diminished ovarian reserve, these can be genetic factors, severe endometriosis together with the age, or the mitochondrial dysfunctions for some patients. So for those patients, as well as for the same-sex couples, for the gay couples, the only solution how to receive the pregnancy and how to continue with their family planning is to use the oocyte donation. That trend and that practical recommendation was even confirmed by the IGFA, and this is very recent report published by the IGFA in November 2022 for the data coming from the previous periods and ending with 2020, because this is the full year which is completed with the received data. And the facts from the conclusions of this report are that the donor conception leads to more than 4,100 births in 2019, which is much, much higher than in the previous years, and nearly 1 baby of 6 babies born using IVF in the UK. This is a donor embryo coming from either donor egg or the donor sperm being used. More than half of the new sperm donors, they were imported materials. So country IGFA allows the biological material to be imported from other producers. So this is for sperm, as the data showing it's imported from the US or the Denmark. For the oocytes, we also are exporters of the oocytes to the UK clinics. So we are also in a small presence, because that was a timing when we just started our activities in the UK, but still the oocytes could be imported, and they are imported, and they are available for the immediate treatment in the UK clinics. Also, the IGFA is supporting donations locally, and this is a great and respectful decision of the IGFA for sure, because as well we are coming back to the fact that globally there is huge need. But even if they are supporting, and the fact say now that this amount of donors which are available in the UK, they are not enough to cover all the needs of the intended parents and the patients who are looking for the options for the oocyte donation. Asian and the Black donor were underrepresented compared to the UK population or the European population. And the generally report, and we all know that in the UK, different ethnicities and patients of the different ethnicities live, and they need a solution. So if there is no availability of such donors in their home country or country they are living now, so the only option would be to travel. But if that would be enough donors, that would be just great to receive treatment in their home city, in their home country. Very important, and this is something what even motivates us to do more and to do better. It's the fact that IVF birth rates for patients aged 43, 50 years old increased from 5% then using their own eggs to 30%. And I believe that this is a data from just one individual cycle. And if we are talking about oocyte donation, we need to talk already about cumulative data. So cumulative data, this is the clinical outcome, which is coming from several treatment cycles, several embryo transfers. So cumulative for oocyte donation definitely should be much higher and is much higher than 30%. So this is really great for such age of the patients. These donors, they are non-anonymous. So IGFA supports also the fact that the offsprings, the children which will be born, they will be able to get the information about their donations. So just as an example of how the algorithm works and how usually the oocyte donor is selected, this is a data which is coming from our donor recruitment, and these are our figures for the just last 6 months. After we are receiving, and we received 841 initial donor contact, either as an online form or the consultation with our specialists or the phone interview from the potential donors, almost 1/3, they were not accepted after that initial talk. So they were not compliant with the basic requirement. Or they were not passing after evaluation and the initial consultation, or they refused by themselves after they learned about all the algorithms and everything what is needed for the program. Another 1/3, they were not accepted by our clinical team already after the medical investigation, the ultrasound being performed, the IMH level being measured, and the gynecological consultation performed. Some were excluded after infection disease screening, and some after genetic screening and the chromosomal investigation, or the hereditary anamnesis being performed by the geneticist. So generally speaking, only 3 out of 10 candidates will become a donor. So this is a very time-consuming, very responsible algorithm of how to select a proper donor. Of course, they are all aware about good clinical practice recommendations for the information provision for those who are using or participating in the reproductive donation. So for donors, they are participating in the IVF treatments, they are participating in the reproductive donations. So there are lots of recommendations and the good clinical practice rules which we are discussing with them, and they need to agree and to follow them. Other criteria for the oocyte donors, these are, of course, the young women between their age of 18 to 30 years old with the perfect physical and the mental health. They are fully screened, including genetics and all infection disease panel, everything. They have proven fertility according to our law, so they need to be mothers. They have at least one healthy child of their own, which also brings a lot of advantages for the further clinical efficiency and the clinical outcome. And they have no hereditary illnesses and the negative phenotypical signs. As for the screening, in order for the donor and the oocyte being produced by this donor to be compliant with the IGFA requirements, we are following the IGFA recommendations and the guidelines for the screening of the oocyte donor, following the testing method for the infection panel and the other tests, the frequency of the testing, we keep the quarantine period, and we release the materials only after they are retested and the quarantine period is ended. Other requirements for the oocyte donor by the IGPA is the fact that they are all non-anonymous egg donors. The supplier, medical center which supplies the biological materials or the donor oocytes, is ISO certified. So we have a quality management system in place, and all SOPs and the standards for every process are respected and followed. The laboratory where we perform the testing is ISO certified, and this is another ISO for the special clinical management and the safety for the medical clinical tests. It's ISO 15189. We are strictly following 10 family limits. We are following family limits globally and the number of the donations by donor, but for the UK, strictly 10 family limits is followed. Donor compensation is according to the recommendations of the IGPA. So we are providing the compensation sheet. So the clinic and the IGPA, they can access how much donor has received as their compensation. The quarantine period, as I said, the complete screening. For the practical experience of the clinics and the patients themselves, we have a separate catalog where only UK compliant donors are listed. So this is not a requirement of the IGPA, of course, but this is a practical experience which really helps to navigate better for the patients and the clinics, and the direct shipment of the biological materials by the certified medical transport companies into the UK. So this is from door-to-door transportation. So we are sure how materials are safely delivered, because this is very important to produce them in accordance to the high quality standards, to transport them, and then to store them in the facility in the UK, and then to sow them, fertilized, and continue with the full treatment. So in terms of the specific evaluations which we are performing or need to be performed for each cohort of the oocytes which we are receiving from the patient, we are checking oocyte cumulus complex morphology, zona pellucida, as I showed on the very beginning about morphology of the oocyte, the perivitallin space, the appearance of the first polar body, oocyte shape, meiotic spindle, which I said is very limited in some other locations, granulations of the cytoplasm, and other morphological parameters. Because in addition to the fact that we are receiving M2, M1, and GV oocytes in the full cohort, we are receiving different morphology quality between the M2 oocytes. So this is, as you are probably well aware about grading of the blastocysts. So by Gardner, we are grading them on the blastocyst 1, 2, 3, 4, 5, and the category. There is A, B, C category of the quality of the embryos. So the same we evaluated and we are practicing in our laboratories for the donor oocytes. So we are grading morphology of the oocyte into Q1, Q2, and Q3. And only Q1 oocytes, which are coming from the cohort of M2, meaning not every M2 is Q1. So some M2s, they can be different shape, they can have too thick zona pellucida, they could have no spindle inside of the eggs. So these eggs will not be used for the further oocyte banking usage. They will be deselected, and we are not going to recommend them to the patients. That all increases the chances for the successful sowing, and the sowing is now for the vitrification process is over 90% in the good laboratories. Our regular sowing survival rate is 95% and up. So this is possible to use really effective all these biological materials. In terms of the transportation, not only we are respecting, or it's recommended to respect the temperature condition, but also international regulations for the movement of these biological materials. And this is well written, and we assess this from the IATA and the ICAO organizations. So this is safe to travel with the biological material while following all the rules. Also, as an almost unique option for the oocyte banking, and something what increases practically the usage of the donor oocytes and the potential outcome, this is the fact that we need to check if there is a spindle in the egg. This is what we were talking on the beginning of our lecture, that if we see that there is a spindle, and also we can determine the location of the spindle, this is very important for the further fertilization. So first we are checking the spindle is present in the egg. This gives a potential to this oocyte to be properly fertilized and produce the zygote in the future, like 24 hours later. And also the fact where the spindle is located. Usually it should be located opposite to the polar body. And the embryologists, they know that because spindle is located opposite to the polar body, they need to inject the sperm while doing ICSI in the proper place, based on the fact where they see the polar body, because the polar body is seen by the regular microscope. Spindle is not seen by the regular microscope. So this is how we are trying to avoid to destroy the spindle while we don't have polarized lights in the laboratories. So that's why we are checking where is the presence of the polar body, and we are injecting in the proper place where should not spindle to be located. But sometimes spindle can move, and it can be located in the different locations in the different place. Not as it usually located. So that's why we are showing also the place of the spindle, which helps embryologists to perform the proper fertilization. And also this increases the chances for every oocyte to produce the zygote and then the healthy embryo after that. In addition to the fact that we are performing such thorough morphological selection for the oocytes, and that we are checking the polar body presence, we do the artificial intelligence selection of the oocytes. So we teach the machine learning already how to select quality 1 oocytes out of the full cohort, and these oocytes are selected for the further oocyte banking. We do NGS testing for the oocytes, but this is another procedure which is a bit complicated, and which should be done also with the cooperation with the receiving center, because while we making polar body biopsy, we can test that this oocyte is euploid. However, this is a different technique, or very complicated technique, which the embryologist who will be doing fertilization in the UK while this clinic is going to receive these oocytes, they need to know how to follow the ICSI and the cultivation process. However, of course, we are sharing this experience, we are learning, we are teaching about this. So this is something what can easily be followed, and just saying that the blastulation rate for the euploid oocytes for NGS testing and the euploid oocytes is much, much higher comparably to non-tested oocytes, because we are avoiding these 20 to 30% of the aneuploid oocytes which we are using in each cohort if we don't test them. So we have them, we understand that we could have them. And also we are checking the spindle, the presence of the spindle, and by this we are increasing potential for the fertilization. And the time-lapse video recording and live image during vitrification process for every egg lot. This also very important information which is shared with the embryologist of the receiving clinic as well. So that's why this is so important to test oocytes, and this is option which is already available and should be used more widely, and the testing of the embryos, because the euploid oocytes, they have much higher potential to produce embryo which will have the highest potential for the implantation patient and which will result in the successful pregnancy in the end. There is always a discussion of how many oocytes we need to have in order to receive a successful pregnancy. So this is true that for the advanced maternal age patient, in order to have blastocyst and to have more ideally euploid blastocyst, we need to have 10 oocytes, from 8 to 10 oocytes. And based on the previous clinical experience for every patient, not every patient or very few patients can really produce 10 oocytes in their age over 40 years old. That's why this is something what cannot be achieved, and that's why alternatives are recommended as a combined oocyte donation or the regular oocyte donation using highly selected and the highest quality oocytes. If we are talking about donor oocytes, we need to have 4 oocytes. So this is the data based on which we are communicating with the patients and recommending the cohort of the eggs to be selected, to have 4 oocytes in order to have the blastocyst. Of course, if we have 8 oocytes, we have 2 blastocysts, we have options for the genetic testing, we have option for cumulative clinical pregnancy rate. So we are not using or having material only for 1 embryo transfer, but for several transfers, which also increases the chances for cumulative clinical pregnancy and the success rate, of course. So this is topic which I like to talk about, because, you know, what if we would have unlimited potential to have unlimited treatment cycles? What would be our clinical pregnancy rate? What would be our success? And this is a data coming from Israel, from a country which where government is paying for the treatments of the patients until they have 3 children in their family. So for them, it's very easy to follow multiple treatment cycles, because patients are receiving these cycles. Not every patient can have even few, 2, 3, 5, 8, 10 treatments. So, and the data says that in case we have unlimited treatment cycles within 4 years, we are receiving almost 100% chances to get pregnant. So meaning we are trying more, we are receiving higher clinical pregnancy rates, and we are closer to the success with each treatment cycle which we are performing. Medical considerations were when to stop or when to consider to stop using your own oocytes and to think about oocyte donation. This is a number of cycles which you have been undergoing before, number of the follicles which are growing or which are responding to the gonadotropins, number of the oocytes retrieved in these stimulation protocols, and quality of these oocytes. IMH level as an initial data, and the blastocyst formation. So the fact are forming the blastocyst or we don't. So based on these questions, answers, we need to think about the alternatives and when to switch from one treatment option to another. So again, a huge data saying for cumulative treatment cycles and the cumulative efficiency, and that even if we have advanced maternal age patients, but we are doing multiple cycles, we are increasing chances for getting pregnant. So we were talking a lot about how to get an embryo and how to get a healthy embryo. However, this is also important to notice that implantation potential is different in every patient. And still, the diagnosis, which is called unexplained infertility, still exists. So you could have been diagnosed, some doctor could write you that this is unexplained infertility. However, me personally, I like the fact, and this is a thesis which was delivered by the well-known professor, which is still practicing. He's very old, but he has been treating many patients from the US. he was saying that unexplained infertility generally means that the physician failed to find the true cause of your infertility. And personally, I believe this is true, that we need to look not only for the option of having a healthy embryo and the nice triple with the good thickness endometrium, but there are some other factors for the implantation which we need to address. This is an endocrine profile and the thyroid function and the antibodies level. This is the immune system activities. This is the window of implantation and many, many other factors, receptor activities, etc. So this is something what also needs to be considered. And while we are treating our patients, now I'm located in Europe, in Slovakia, but patients can come. They cannot come into Ukraine to receive their treatment due to the situation which is happening, unfortunately. But we had many, many patients who were visiting to be treated. So these are all factors which we need to address, which we need to check prior to the fact that we are going to do an embryo transfer. So this is how we can optimize the clinical efficiency, how we can optimize the quality of our treatment in general, and to receive as high results as possible during the first embryo transfer attempt, as I said on the beginning of our conversation. So to conclude my today's talk, oocyte banking is the best solution for the effective egg donation treatment. We are having loads of data to prove this, and we used to say that the gold standard was to use fresh donors for the fresh oocyte donation. However, with the presence of the oocyte vitrification, with the high skills and the good experience for the laboratories, both clinicians and the embryologists, oocyte vitrification is the same, equally effective as the fresh oocyte donation cycle, even having some more additional benefits as the immediate availability of the oocyte, proven availability because donor can mix up the trigger. We never know how many oocytes she will produce. We need to synchronize the cycles for the fresh cycle and for the vitrified we don't. So there are many, many benefits. Dedicated teams of professionals should be involved, and also the equipment and the new technologies which are available. Effective implementation of the oocyte vitrification has made it possible to discover the new opportunities for treating the patients. The use of the vitrified oocytes can be considered now as a gold standard in the reproduction. Individual approach to each patient or cycle allows us to effectively influence the result, and this always should be an individual approach for everyone. Once all clinical, embryological, and the organizational aspects are considered, like following the laws, following the regulations, international requirements, etc., the cooperation between clinics and the countries can be lead for the benefit of the patients. New trends are actively in the research phase, and they can be routine soon. In the new trends, we may talk about different cell engineering technique, pronuclear transfer, mitochondrial donation, but they are very limited. But we need to remember that 40 years ago, we had no IVF at all, and that was all experimental, and we didn't believe on the fact that that will be a routine. So in our practical experience, we also do pronuclear transfer and mitochondrial donation. It's not allowed in the UK, and now it's well regulated. However, that was possible in Ukraine, and now we have another country, which is Albania, where we can practice this, and we do practice this. So the second opinion is always recommended for the complicated cases, because while there is one doctor who is following all your treatment, it's great. He or she knows everything about you. However, if he is not allowed to use some treatments or technologies, or they cannot be accepted in their home country, or by just the presence of the equipment or absence of the equipment, this is how and why the second opinion should be valuable. So this is generally all information I wanted to share with you, and our details and my team contacts are here in case you will have some other questions. Is there any question regarding the treatment or something specifically for the Ovogene activities and the oocytes from Ovogene for your treatment, or the transportation of the biological materials? So you have contacts of Alina and Peter here, and of course myself. I will be happy to communicate, and now I will be happy to answer your questions. Thank you for listening and for your time.
Thank you, Dr. Uliana. That was really interesting. Loads of facts and figures to get our heads round. If anyone's got a question, and there are a couple, just pop them in the chat box, and I'll just start right away so that we get through all of the questions. So first question we've got here is, this person's had 4 miscarriages, 3 chemical pregnancies and 1 miscarriage, all naturally conceived. They're now thinking of IVF. They're age 37 and their AMH levels are 10.9. Would you think that person needs to consider donor eggs?
Yeah, thank you for the question. It's a very practical question. And we need to understand that the reasons for the miscarriages are different. Most common reason for the miscarriage is genetic abnormalities of the embryo and the fetus. This is true. However, it's very important to know or to evaluate. So maybe you had some histological evaluations of the material after the miscarriage to check either that was genetically healthy or unhealthy embryo, because also some different issues can cause the miscarriage. For example, immune issues or the issues related to the thrombosis, the factors were related with the thrombosis. So this all together is very important to analyze in order to think about what next to be recommended, as well as important to know what age are you, and you are not mentioning here, but this all naturally conceived. So I believe you are.
I think they said they were 37, Dr. Uliana.
Ah, okay. Yeah, okay. So then I think that this either or. So we need to see if there was some genetic testing available for these materials which were miscarried, or the embryos, the fetuses. Yes, if yes, so what's they are found? If no, so that should be recommended. But generally, as I said, most common issue why we have a miscarriage, this is a genetic cause of the embryos. So that's potentially oocyte donation should be recommended, but more information is needed and more investigation is needed.
Thank you. The next question is there any way to naturally increase the number of eggs and the quality of those eggs over the age of 40? So can you
natural ways to increase the egg quality over 40?
Yeah.
This is there are different points which we may talk about. These are supplements, vitamins, antioxidants, androgens, which are also included in the supplements, etc. But if we are talking about proving either this is really effective or not, so there is nothing to be really proven to be effective. As a complex solution, this may work. However, again, we need to have the stimulation, we need to produce the egg, we need to control the quality and to analyze the quality of the egg and the embryo which is coming from there. There is a PRP as an also experimental treatment technique, which usually it works for some category of the patients, and also we used to recommend this and we used to practice this, but it helps to produce more eggs. However, it still is not changing the potential for the oocyte to be euploid or aneuploid. So we just need, meaning we need to have more initial number of the oocytes in order to statistically or mathematically to receive this euploid oocyte and euploid embryo out of there. So this is something what really works. So if we do more cycles, if we accumulate the materials from each cycle and then we test them, so this is how we could assess healthy oocyte or healthy embryo. But nothing else is to be really proven.
Thank you. And another question here. Could you talk about the AMH and AFC levels in women over 40 and what those implications have?
It's very individual because mostly these patients are having IMH level less than 1 picogram per milliliter. But some patients who has been PCOS patients while they were younger, they could have higher IMH level and higher number of the antral follicles to be present. However, as well, like higher number of the follicles and the oocytes received, it goes into the correlation with the exact amount of the euploid or aneuploid embryos to be produced, but it helps to produce, to find between all those numbers of the oocytes or embryos, healthy ones. So IMH and antral follicle count are decreasing. However, there is no one sign to be said that it's the same for everyone. It's very individual. For instance, we can see premature ovarian failure, and we sometimes we meet patients in their 26, 28, early 30s, and they have 0.1 IMH level and only few follicles available, and they never had surgeries, nothing like this. So it's still happening.
Okay, thank you. Another question here. Does Ovogene allow the exclusive use of a donor when no one else can purchase eggs from that donor?
This is possible as an individual request, because in our data, we have an electronic system where we control the number of the donations from the patient. And this is how we also control number of the oocytes used per country, per clinic, and also globally. So how we follow the family limit. So some donors, they agree or they are saying us that we are going to donate only once, and we can dedicate such a donor to the individual who wish to have only donor donating one time. Usually, like if you are asking me a data, that will be maybe less than 10% of the donor who are donating only once. Usually donors, if they are going through these procedures, there are different reasons or different motivations for them why they are donating. However, if they are going through one procedure, they should not be that thoroughly retested if they are happy and dissatisfied with the team. And we are usually taking great care about them during the stimulation the period and after that, so they are deciding to go for another stimulation sooner or later. So, and we have a limit of 6 donations during their whole life, during time of their donations. So this is what we are controlling. But we could have donor who will be exclusive donor just for one donation, but that should be communicated through the team, our team, with the patient, and then we will be able to offer that.
Thank you. Somebody else has said, thank you for your presentation. It's been really interesting. And what they're wanting to know is, do most people travel to your clinic or do they have their eggs transferred to the UK?
No, I would, maybe you didn't understand me during the webinar, but I am supporting the fact to build the relationships between the clinics. So I used to treat a lot of patients myself while I was in Ukraine, but that was already a long time ago, like last year, which was really busy. It was 2019 before the COVID. And we've been treating patients from over 30 countries, and we were extremely busy there. Now I'm located in Slovakia. I do not recommend anyone to go to Ukraine right now. It's really risky, dangerous, etc. But still, many patients, they have their embryos stored in Ukraine. So we, from our clinic, we took the storages, we took our banked eggs and the embryos, which were embryos of the international patients, and we moved them into the EU, and they are now stored in the licensed facility in Slovakia. And this is how patients can be sure about safety of these materials, and they could have their treatment continuous in these countries, or they could ask to ship their materials somewhere else where they can continue their treatment. So, but I'm not, I like to treat patients myself, and I'm happy if you would consider to do this, but I am supporting the fact that if this treatment option is available in your home country, we would better work with your clinic or medical facility to import the biological materials, and then you will have an option to be treated in your home country with your clinicians. That will be really comfortable, and this has lots of benefits. So I've been involved as a medical coordinator many years ago. This is how I started to be involved in the IVF in general. So we were creating embryos, and we were sending this to the another facility, and these embryos were transferred in that country to the patient. So that works perfectly. Just clinical teams, as the doctors and the embryologists, they need to communicate, to work together, and then the patient would receive all benefits as being treating in home country. That's why I mentioned about how we comply with the IHFA requirements, and that we are listed in the IHFA list of the third-party suppliers. So we are there, we are trusted facility, and we may bring high-quality oocytes for your needs into the UK, and then you will get treatment there. However, options for the treatments in Europe, now in Europe, not in Ukraine, are also available.
Yeah, I think that's what the person meant. And yeah, for anybody that is considering donor, yeah, there is, that is something that's widely done by lots of UK clinics, that they actually import the donor eggs they use, because there is a real shortage in the UK. So you might actually not even be aware that Ovogene might actually be the egg bank that's actually supplying any particular clinic.
Yeah, this is our aim, actually. Thank you, Sharon. Yeah.
But by the same token, some patients actually want to be treated in an EU country, and Ovogene do work with lots of different countries in the EU. Okay, next question. There's no question stupid, so don't even start off saying this may be a stupid question. But if you use a donor egg, will the embryo contain any of my DNA as the pregnancy carrier?
No, the DNA is coming from it's a nuclear DNA. So we know that there is a nuclear DNA and the mitochondrial DNA. This is how the material is dedicated, how created. So there is a 50% from the nuclear DNA of the mother, coming from the egg, meaning if you're using oocyte donation, this 50% is coming from the donor, and then the 50% is coming from the partner, from the male. There is a mitochondrial DNA. It's up to 2% of the DNA. It's nothing it's more responsible. It's responsible for some diseases and carrying some genes. While we are talking about, for example, we are talking about 3-parent babies, which is still experimental, or which is in the UK allowed under the special circumstances after the committee decision for the patients who are carriers of the mitochondrial diseases. So they may exchange the DNA from the mitochondrial DNA from the donor. So that's in this case, there will be three DNAs which will be in the embryo. The embryo will consist of. However, if we are using regular oocyte donation, there will be no DNA from you as a pregnancy carrier. That will be a DNA coming from the donor, both mitochondrial and the nuclear DNA, and as well from the patient from the male side, mitochondrial and the nuclear DNA from the male.
Thank you, Uliana. I've got another question here that was asked beforehand. This lady went through an early menopause, so she's now postmenopausal. How is her body prepared to support an embryo created by donor?
Yeah,
and she's already been through all the changes.
Mm-hmm. Yeah, that's a great question. Thank you. We may receive a pregnancy almost in any time when the uterus or the endometrium will be receptive. That's why, like, different countries, they have different age limits. For instance, in Europe, in most countries in Europe, it's 49 years. In some countries, it's 54 years old. Some countries do not regulate the level of the age of the patients while IVF could be performed. It should be reasonable for sure. But generally speaking, until the uterus can be well prepared. Even if the patient is in her menopause, we don't know what her age is. However, if she has the uterus, we need to get it cycling again. So we need to give her hormonal replacement therapy in order to start cycling her uterus, meaning she would need to get back her periods, at least several periods. Also depends on what is the size of the uterus, because this is important for the further pregnancy care. So that should be at least 35 millimeters. That there are some measurements which we need to start with in order to confirm that we can transfer, and that will be safe for the patients. But also we need to get her cycling with the hormonal replacement therapy. Usually, if the period of the menopause is not too long, 2 or 3 cycles are enough before we will start the endometrial preparation. And then we are starting endometrial preparation, growing her endometrium, and may plan to have a transfer.
Thank you. Somebody's asked about oocyte rejuvenation, which is not something that is available in the UK. Would the baby have the DNA of the patient and the husband only?
Yeah, the oocyte rejuvenation procedure, usually now this is how we call PRP procedure. So that's while we are preparing the autologous plasma and injecting this into the ovaries of the patient. There are some new experimental as well. Generally, PRP is experimental, but also it may consist some other cells like growth factors or some others, and then we are injecting this into the ovary, and this is how patient is starting to produce more follicles. But that should be really well selected group of the patients, because they need to have a potential to produce the follicles. While following the follicular genesis and the development of the antral follicles and the producement of the follicles to be ready to respond to the gonadotropins, it takes almost 200 days to come from the pre-antral follicle until the mature follicle, which can be responding to the gonadotropin. So this is quite a long period of time. That's why while we are having PRP procedure, what we usually see that we can force a little bit faster development of this pre-antral to antral follicles. However, we are not getting really more follicles. We are not getting new follicles as a result of this procedure. So if we will force more follicles to grow and we will get an egg from this follicle, that will be an egg which will be produced by the patient. And this egg will consist the DNA from the patient, meaning if that will be successful, then the baby will be carrying 50% of the DNA of the mother.
Okay, thank you. Now we're nearly out of time. This will be our last question. Does Ovogene keep a rate of success rate per donor IVF cycle? So do you have success rates based on your donors and the number of patients that are managing to achieve a pregnancy?
Yes, absolutely. Absolutely. This is very important parameter of, as I said, initially we are selecting donors only based on the characteristics, initial characteristics, antral follicle count, IMH, if she is healthy, etc., etc. But once we are deciding to continue with these donors or invite them into the next cycle, so we are evaluating the maturation rate of her oocytes, like a full cohort of the oocytes, then Q1 oocyte percentage out of the full cohort of her oocytes, and then the efficiency, of course. So we are asking every center, like in case the treatment was not performed by us, but we send these eggs, for example, to EV London or to City Fertility. So these are the clinics we are working with in the UK. So while they were using these oocytes, they are sending us the efficiency report back so that we know how many oocytes were successfully survived the thawing, how they are fertilized, how many blastocysts we received, and if there was clinical pregnancy or no. So, and we have a grading of our donors based on this data. So we have some donors which are like, we are joking, calling them VIP. So we have excellent success rate coming from them. Of course, we need to understand that it's not only depending only on the donor. There is a sperm there is a potential of the patient to implant the embryo. So it's not fully responsibility of the donor, but we are keeping for all donors the data about their previous clinical efficiency. And if this is important for the patient, we are sharing this as well.
Uliana, that presentation has been fascinating, and I still have another couple of questions, but our time's running out on us. If anyone's got further questions, please email me, sharon@fertilitynetworkuk.org. What I'll do is I'll pass those questions directly to Uliana for a response and get them answered to you. Can I thank everyone for attending, and for the people that didn't make it, but we'll watch this on the pre-record sometime later. That also goes for you. If after watching this you think, oh, I wish I had the opportunity to ask a question, just pop me that question over and I'll get that response from Dr. Uliana. Once again, Dr. Uliana, I just want to thank you for taking the time, and to Ovogene for giving us your time to actually come along. It's been really educational and been really interesting. So thank you everyone for attending, and I thank you especially to Dr. Uliana.
Thank you so much, Sharon. I really appreciate, and as I said, I'm always happy to share our experience, our knowledges, and to help the patients. I promise we will answer all the questions, so do not hesitate to write us. We will dedicate the time and immediately we will answer them. So if you need to analyze something, or something was not clear, or you need an advice or something, so you are welcome to write. And again, that was my pleasure to spend this evening with you, and I hope that was really helpful, and I hope we will see each other again sometime, someday.
Okay, thank you. Bye.
Thank you. Bye. Take care.